Alfredo Moravia. He came to us in the mid-1980s following completing his internal medicine boards in Switzerland. He received a PhD from Epi in 1989 and an MHS in biostatistics, so another double hitter. He returned to Switzerland, where he served as professor and head of the division of clinical epi at the University Hospitals of Geneva from 1990 to 2006. When he moved to New York, joined the faculty at CUNY and at the Mailman School, and as you're going to learn shortly, he has focused more recently on the history of epidemiology, and I think with the idea that the past can give us a lot of hints about where we're going in the future. So, Alfredo.
Thank you, David. Just a second. Okay, thank you very much for inviting me, David. Thank you, Moses. And frankly, I see a lot of familiar faces, even though it was a long time ago I was here. And even though the place looks physically different, it feels the same. And the department has not changed. It remained extremely challenging for its members and its guests. Because here I am, granted 15 minutes. At the origin, in the email, now down to 12 minutes. To talk to you about the past, the present, and the future of epidemiology. Thank you so much, but please do me a favor. Can you put on your seatbelt? Because we're going to cover 350 years at an average speed of probably 25 years per minute. So I think one way of rewording the question is that, is there a single, simple idea that can thread together the past and the present of epidemiology and can allow us to predict, say something about its future? So I propose the following idea. That the emergence, evolution, and refinement of epidemiologic methods and concepts appear to be motivated by challenging health problems in public health or in medicine, often associated with major changes in society. I'd like to show you that with some example across the century from public health, from medicine, and if you agree with me, we could talk about the future. So let's look at the past. And the oldest past for epidemiology is the 17th century, 1650. Before that, there is no epidemiology. And by then, that was the 17th century, a very difficult century with lots of crises, economical, political, and social. And a major health concern then was the plague. And the plague had been in Europe since the 14th century. It was bubonic plague, but it was recurrent, and in the 17th century it was a real obstacle for the existence even of the state. It was paralyzing society, and as you can see here in this broadsheet from the 17th century, when the plague was around, people were escaping London by boat or on land. So the city was emptied. Most of the civil servants were away. The parliament didn't meet. So the entire city and the state was paralyzed. And the King of England had asked the church, which was one of its state institutions, to actually centralize and publish the data from its parishes about the death, and in particular the death from plague, and those were the bills of mortality. And actually our first pioneer of epidemiology, John Grant, seized that chance and actually tabulated this data and tried to see whether he could say something about the plague that could be useful. And even though he didn't use R, he just used table, but by then it was just as revolutionary as R is today. What he found was extremely surprising. Not so much the way the plague behaved like shark thieves, very because this people could expect, but it was the contrast, because here you had the total number of deaths and the total births, and the regularity of events in population was something unknown before that. And the contrast with the plague led him to say that it was most likely an environmental factor that came in and out of London, and that may have helped, to control the plague. By the end of the century, 17th century, the plague had quasi disappeared, and maybe that, Ground's book was a bestseller, and maybe has contributed to that. And let's move to the following century. The 18th century was a much more prosperous century. Plague was away, but smallpox was still there. And even though smallpox was had a lower mortality than plague, it killed at the head of the states. It killed the queens and the princes and the kings. And here you see Balthazar Carlos, who should have become king of Spain. And you have here Louis XV, who was king of France, and Mary of England. Many kings and queens and princesses died of smallpox, and so it was a very important issue of the 18th century. And our pioneering ancestor, here you have John Arbuthnot and James Durin and Thomas Nettleton. They tried to see whether inoculation could be a solution, and because inoculation was available, it could be help to prevent smallpox. But the question was, did it kill less or not than the natural smallpox? And they look at the bills of mortality. They found that smallpox killed about 10% of the people, and then they collected data from inoculators, and they found that actually artificial smallpox killed only 1%. And so there was a 10-time reduction in risk. Benjamin Franklin had been convinced, and probably also George Washington, since before Jenner he got the Continental Army inoculated. So that was for the 18th century. Before we leave that century, we need to go and shake the hand of James Lind, because he was also from that century. But I won't tell you his story again about how he tested the treatment of scurvy. I just want to show you, if you didn't know it, the type of boat in which he did his experiment. So let's move now to the 19th century. Another terrible century, at least started in a big chaos, industrial revolution, large cities, concentration of people, very low level of hygiene. And in the middle of this real chaos and misery, here comes, knocking at the doors of Europe and America, a new scourge, and that was cholera. A terrible disease, that killed people in a few hours and led them like desiccated corpse with an entire blue skin. And the sanitarian, they thought that it was due to air pollution. And in order to prove that it was not due to air pollution, here again I'm telling you something that you know very well, but it's a milestone. John Snow had to come up with a new design, something that no one had done before, that he could compare people who were just exposed to the same type of air pollution but differed by their exposure to water. As you know well, he compared those people living exactly the same neighborhoods, but some drank polluted water and others not, and it showed that the risk was higher among those who get polluted water. So that was the public health example of the 19th century. There's a very important medical example, because the 19th century is also the appearance of very large hospitals, and those hospitals concentrate hundreds of patients, and so they were an opportunity for our ancestor to start to assess the efficacy of treatment, and that's what Pierre-Louis did with bloodletting, or also assess, the complication and the consequences of medical practice. And that's what Semmelweis did, when he showed that combining anatomopathological teaching and the bedside teaching, could create epidemics of puerperal fever. So that was for the 19th century and their main issues and how epidemiologists improved their methods. And let's move to 1900. That's a more prosperous period again. Most of the scourges of the past are gone, but there is still one that is problematic for people in public health. Tuberculosis remains very prevalent, remains a major killer, but especially it looks very different than it used to look. This was how it consumed people in the early 19th century, and this is how people could live with tuberculosis, have children and family, etc. And so in this atmosphere that was really dominated by eugenics and racial hygiene, pre-Nazi racial hygiene, very different stuff, in Germany, they were wondering, well, if the tuberculosis can live longer, are we all going to be once tuberculosis and the whole human species is going to disappear? And the one who addressed this question was Weinberg in Germany. You know him because he's the Weinberg of the Hardy-Weinberg equilibrium, but here is Weinberg as an epidemiologist, and in order to show that the people with tuberculosis live, longer or shorter lives than those without, he couldn't do cross-sectional study, he couldn't use any of the design that were available before. So he invented a new design, which was a cohort study based on registry, but huge cohort study in which he followed up to age 20 thousands of children, some born of parents with tuberculosis and some with not, and he showed that tuberculosis was not an issue for the survival of the race because they died earlier and had less children. And indeed, tuberculosis from 1900 to 1940 was declining. But there was another disease that was rising, and this was cancer. And this was the medical example, because cancer was something new, relatively rare. And where would you find cancer? In hospitals, in medical practices. And how would you study cancer? Well, the logical way that had to be invented then was to take those cases, concentrate in hospital and hospital practice and medical practice, and take people without the disease and compare them with respect to past exposure. And that's what Janet Lane Clapon did with the first case control study that we can really consider as such in 1926. Was a breast cancer case control study where she found most of what we know today about reproductive factors associated with breast cancer. And there were other cancer case control studies, like Herbert Lombard published in New England Journal of Medicine 1928 from Massachusetts data, or Percy Stocksy in England. But there was another disease which also interested and preoccupied doctors more than public health, and this was ischemic heart disease. And if you see here, Dr. Hayes shows you the situation today, but it really started around 1900. I mean, it could be also a problem of identifying the disease, but after 1940, it's pretty sure that this is what happened. Before that, it's quite extrapolated, but it was a new disease that doctors were seeing in 1920s and 30s. And same thing as cancer, they started to do the first case control studies. And they looked at tobacco very early, and this one is 1929 in JAMA, and 1937 in JAMA, and 1940 in JAMA. All case control studies of cardiovascular disease. So this brings us to the second part of the 20th century. And at that time, one thing that had become very clear is that there was a huge epidemic ongoing, and this was an incredible success of tobacco and cigarette smoking. You see cigarette sales in the US across the century. I mean, a huge success, huge rise, followed by the trends in lung cancer that you know pretty well. And this became, this topic of main interest in public health after 1945. And as you know, also, that was the occasion to develop, improve the case control study design, improve the cohort studies for cancer, but also for cardiovascular disease. And you know those names. And so this was for the public health, but there's also very important changes at the medical level after 1945, extremely important, which attracted the attention of epidemiologists. First of all, treatment. Unprecedented number of pharmaceutical drugs, of hormones for contraception in particular, and other vaccines. They needed to be evaluated for the side effect, but also for the efficacy. And they lead, it's been a long process that Cochrane, led. It started quite early, but it led to the Cochrane collaboration. And the other thing which was led in this school was the issue of screening. An unprecedented number of technical, instruments that you could use at the mass level to screen for disease. And they need to be evaluated, and that's when we started to evaluate screening with randomized trial, and this is the famous, HIP randomized trial. So the people who did all that, you know them. They are probably, for those of my generation, I don't know about the other. Those are all familiar faces, and Lilienfeld, and Morris, and Susser, and Winder, and Breslow, who just died, and Dahl, and Cornfield. Those were the classic epidemiologists. They did all these studies and these developments. And I think that today, we go to present now, and I hope I'm still in the time. We have modern epidemiology, but I think essentially here you have, the general textbook and specialized textbook, many specialized textbook. I think in the essence, they are elaborated. They have a theory of design, of disease occurrence, of confounding interaction and everything. But essentially, they remain classic approaches in the sense that the objective is to identify the one single cause that may explain most of the disease occurrence and on which we could act to try to reduce that. I think that's what characterizes modern epidemiology. It's still part of the classic epidemiology and all the work that has been done on cancer and cardiovascular disease. So let me see if my hypothesis has been, kind of illustrated. I said the emergent evolution and refinement of epidemiologic methods and concepts appear to be motivated by challenging health problems in public health, medicine, often associated with major change in society. So plague, smallpox, cholera, cancer, cardiovascular disease. So if this is true, it tells us where we have to look to know where the future is. And in order to know where the future is, we have to know where the health of the public is going. And that's where this is probably what is going to stimulate the further developments of epidemiology. And I think, as Dr. Hay has shown very nicely before, the main issue now are kind of, I don't know how to call them exactly, but complex traits fit well in the sense that they don't have a single cause. They cannot be modified or changed by a single intervention. They are quite complex. They are metabolic, they are neurodegenerative and psychiatric, infectious diseases, aging. All these factors need different approaches. And we know that people are looking around to find these approaches, much more multidisciplinary approaches, separation of explanation, which allows for a lot of complexity, and intervention, which needs to be reductionist and focus on specific issues, life course analysis, causal models, global monitoring and surveillance. All this tends to shift the place of epidemiology in science. I think epidemiology has always been kind of central in the scientific networks, but I think now more than ever, epidemiologists are finding themselves in the center of, fonts of huge amount of data, but also huge amount of works in other disciplines. And this is what requires new skills, and I think schools of public health need to prepare themselves to address those issues and train their students in order for them to be able to play this type of role that is expected from them. And when you think of the role of the situation of genetic epidemiology today and the role epidemiologists play in those networks, I think it talks about where the future is going. So I think I see the future with changes in the training. But there's one point, David, which I'd like to mention that should be part of the training of the future epidemiologists, and this is history. Don't forget that our past is a fabulous trove to search for answers about our future. I mean, when you have questions about the future, wonder whether there are no answers already in the past. Because the past, our history, and you'll soon see it because the thing is slow, is a huge domain. You know, you can ask a lot of questions, and you can wonder why some groups succeeded and why others failed, and how people react in the past to the change of societies and change of the health of the public. And I think this can inform us about how to do better in the future. And thank you.